you obviously have to evaluate the patient. And the initial evaluation consists of the history, which is a very important part of this. There are a lot of questions that can help point to which type of incontinence someone has, how often they lose the urine, when does this mostly occur? Does this occur when they are coughing or sneezing or exercising, and or does it occur just at any particular time when they're walking in the mall and they all of a sudden have to urinate very, very rapidly, an urge that they can't control? How much urine usually is leaked, and what provokes the leaking? Again, is it cold? Is it exercise? What improves this, if anything? And if someone's had any past treatment, that's also very important. Medicines can contribute to urinary incontinence, which a lot of people don't bring up, but certain sedatives like alcohol, oftentimes over-the-counter antihistamines can cause urinary incontinence, and antidepressants, a lot of different medications that are listed here. Previous surgeries can contribute, as well as vaginal deliveries, stretching the muscle. How long has this been going on? How long has it been appearing and seeming to be a problem to you? Also, medical problems can contribute to urinary incontinence, such as diabetes. People who don't know that they have diabetes, it's often a symptom. People who know that they have diabetes but don't realize that this can be a problem with diabetes. Vascular insufficiency usually causes more urinary problems at night when someone's lying down. Someone with a chronic cough because of pulmonary disease, lung disease, chronic smoker, emphysema, different bronchitis, things like that can cause urinary incontinence to worsen as well. And neurologic disease such as a stroke, multiple sclerosis, or Parkinson's disease can cause urinary incontinence. So along with the initial history, physical exam is very important. And what we try to do on the physical exam is actually provoke the incontinence and reproduce this incontinence. There's also obviously anatomical problems that can cause urinary incontinence, and so physical exam is obviously important to make sure that none of those things have appeared. A lot of the anatomic problems are diagnosed in infancy. And a ureter that's come out at a different spot that causes continuous dripping. When a baby's diaper is constantly wet, it can be a sign of an ectopic ureter, or a tube that goes from the kidney into the wrong spot. Nowadays, and in industrialized countries, most often there can be an anatomic issue with people who have undergone surgery or had certainly a traumatic delivery. Vaginal delivery can get a fistula, and that is actually a tract between the bladder and the vagina, or different other tracts, but as far as urinary incontinence, that's the most common. Malignancies or cancers of the bladder, the vaginal cuff, even the uterus or cervix can certainly cause this tract to start developing. And people who have had radiation therapy for various reasons can also have damaged tissue and therefore have urinary incontinence. Another part of the initial evaluation is to actually, obviously, test the urine when the patient comes in and is complaining of urinary symptoms. A culture is very important, and a urinalysis just to try to detect if there is anything such as infection or blood, certain things that we look for to try to detect reversible causes and or detect any bladder problem. So you can't hear me? I'm sorry, can everybody hear me? Okay. So another thing after we do have someone urinate is post-void residual. In other words, catheterizing the patient after to see if there's a lot of urine still left in the bladder, and that can be signs of certain other types of problems that can help us diagnose the incontinence. Simple urodynamics are also done frequently in my office, and when none of the other things have actually shown to be helpful in detecting which type of incontinence. And simple urodynamics for me would be the initial having someone urinate, a post-void residual, and then actually taking that catheter and filling the bladder with urine and seeing when the patient's first urge to urinate is, to see how full their bladder will allow them to be, and then when actually they have to urinate or when they leak, again, trying to provoke their urinary incontinence. And this can tell me the capacity of the bladder and what might be causing the incontinence. So another very important part of the initial evaluation of urinary incontinence is actually avoiding record or a urination record, basically having the patient go home for a week period of time, writing down